Afternoon, dear participant, and welcome to the National Distance Learning Seminar Series. The topic of today's session is STI, RTI among people living with HIV, understanding synergy and management. Today we have Dr. Lakshmi Prasad with us. Dr. Lakshmi Narasimha Prasad Turlapati is a virologist and family physician with more than 2 decades of program experience. He is from Andhra Pradesh Medical and Health Science on Leon to NACO, where he is working as technical expert since 2007. Prior to coming to NACO, he worked as a deputy director at AP Sachs. Incidentally, he was the first ART consultant for AP in 2004. He worked with WHO, RNTCP, STB HIV consultant, with FHI as a technical manager, STI capacity building team. He is a regular participant to national and international conferences and co-author on 11 publications. He has represented India in various global meetings organized by UN agencies. He is a member of various professional associations like IMA, ASI, IASSTD, and AIDS and IPHA, and has received Dr. Govindan Nair and Dr. Rangarajan Award. He has delivered Institute of Virology Silver Jubilee Oration in 2012. He has designed and implemented on hands-on training for doctors working in district and teaching hospital at Andhra Pradesh at Mumbai in 2003. We welcome you, sir. Please take over the session.
Thank you, Vinita. Good afternoon to all of you. I hope you are all able to listen. Okay, today's topic, as Vinita has already said, we are going to discuss in the coming 1 hour about the STRTI management among the people living with HIV and AIDS. And underneath that, we also understand what is the rationale for this, and what is the synergy, and what are the special precautions we need to take while addressing the STRTI among the people living with HIV. With this background, let us start the presentation. Now my presentation has 4 components. One is, we will try to learn what is the rationale for this. The second, we will try to understand the interactions between the STI and HIV. Then the third is, a brief overview on syndromic case management. And lastly, specific points with reference to management of STI among the PLHIVs. Then of course we will take any question and answers, and please feel free to interrupt me, and you can also chat in and then write down your questionnaire. Now coming back to the rationale, what is the relation between the STI and HIV? Number one, HIV is also an STI, and STIs are a group of infections which are predominantly transmitted by sexual mode. When we talk about the sexual mode, it can be a close physical intimacy, may or may not be related to penetrative sex. That means it is more like a sexual behavior oriented, and both STI and HIV are sexually transmitted mostly. Of course, there are other modes of transmission. And epidemiologically, populations with high rates of STI show disproportionately high rates of sexually transmitted HIV. Okay, this is more widely seen in the generalized epidemic settings. Even in the concentrated epidemic settings also, we are observing the same kind of a phenomenon. And lastly, immunologically, the STI facilitates sexual mode of acquisition and transmission of HIV. Now, if you look into the universe of people living with HIV/AIDS who are coming to your ART centers, now they can be broadly divided into 3 subgroups of population. One, some of them may be belonging to the core group, like female sex workers, men who have sex with men, transsexuals, transgenders, people who inject drugs. Then we also have clients from the bridge group. They constitute clients of sex workers, truckers, migrants. Then finally, we have the general population represented by a monogamous woman and their children. So when you look into the universe of the people living with HIV coming to the ART centers, you have this kind of a distribution among them, and you also have people who are not affected by the HIV. That means the discardant people. Maybe they are the women or men or children, and they may be there among these three different subpopulations also. So in any kind of a STI transmission, the dynamics follows a bidirectional way between bridge group and core group to bridge group, and a unidirectional way from the bridge group to the general population. So it applies to HIV, not only to classical STIs like syphilis, gonorrhea and other things. More than 85% of the HIV which is reported in the ICTCs is said to be predominantly through unsafe sexual practices. That means risk of STI is almost equivalent to risk of acquiring HIV. And further, either STI or RTIs increases the transmission risk of HIV by almost 4 to 10 times. It depends, varies on varieties of the STI and other things. As on today, nearly around 35 different kinds of pathogens are proved to be sexually transmissible. Now you can divide them into bacterial, viral, protozoal, parasitic, so on and so forth. There is also an epidemiological synergy between the STI and HIV. If we can detect and prevent early the STI, then the not only individual but also the community level, we can see the prevention efforts gets multiplied and the HIV transmission gets reduced. And identification is also important from a public health standpoint of view, because an STD, once you diagnose, it is not only a clinical diagnosis, but it is also telling to us something very important. That is, there is an index case in the community who is not or who is yet to be treated. The individual who came to us with an STD has not practiced safer sex, and there is a possibility of the individual with HIV and STI is an efficient transmitter, and he may be in a better position to transmit HIV to uninfected or already infected person. So there is also a dissociative behavior. I'm sure you must all heard about this word. Now, dissociative behavior in the sense, with the prior to 2004 in India, there was no antiretroviral therapy. And since 2004, National AIDS Control Organization has made rapid progress in scaling up of the ART services. Today, from a few less than 10 centers, today we have almost 300 centers spread across India. There is also a lot of empowerment done to the community of the HIV infected people, and there is some kind of a false sense of confidence has come, because there is a treatment. It is no longer considered as a deadly disease. It is a chronic manageable disease like diabetes and hypertension. As a result, there is no need for me to follow safer sex practices. This is called dissociative behavior, and this is a very a dangerous sign. I request all counselors to emphasize on safer sexual practices apart from genital and coital hygiene at each and every interaction with HIV infected and affected community visiting the ART centers. Now, if you look into the percentage contribution of the new infection between the people who are aware about their HIV zero status and who are not aware about the HIV zero status. Okay, if you see here the left hand side bar, it shows to us out of the 100 HIV infected people, around 25% are unaware and about 75% are aware about their zero status. But what percentage of them are contributing to the new infections? The new infections, 54% of the new HIV infections are contributed by 25% of the unknown serostatus individual and 46% by the 75% known. That means, irrespective whether they know or don't know, the sexual mode of transmission of HIV seems to be more efficient, more contributory in factor. As a result, emphasizing and educating them on safer sexual practices is a very cost effective kind of a intervention in the whole prevention package. Now, there is recently a paper published in British Sexual Transmitted Infection Journal of 2013. It describes about the risk behavior and the STI among people living with HIV/AIDS. The study was conducted in Belize somewhere in 2012. It's a kind of an IBBS study where they have recruited about 252 people living with HIV. More than half of them were female. And the sample has been recruited from 3 districts in the Belize, which constitutes about 80% of the HIV burden in the country. The median age was around 45 years. Most of them are found to be with low monthly income, and nearly 1/3 of them do not have a current stable partner. And there is also a low percentage of consistent condom use with stable partners wherever they are present. Now, if you look into the distribution of the STIs among this community, nearly 83% were found to be having type 2 herpes simplex virus, and around 40% of the females had trichomonas, and significantly there is almost 2% also of the males also had trichomoniasis. And almost 13% of the females and 18% of the males were found to be having mycoplasma genitalium. And incidentally, the most common, once upon a time, most common bacterial STI like syphilis and gonorrhea seems to be at lower level, at par with other countries in the world. Now, what it is saying, it is saying that even though they are HIV infected individual accessing ART, coming regularly to the ART center, still educating and counseling on them on the safer sexual practices and risk reduction, which may be a customized plan, will be a better way of dealing this. There is another paper in PLOS One published in 2009. It talks about STIs among HIV-1 discordant couples. In about 416 HIV-1 discordant couples, the correlates relating to socio-demography, behavioral and biological are being assessed, where HIV-1 infected partners were HSV-2 seropositive. I want you people to take a note of this. HIV-1 infected partners were HSV-2 seropositive. They were tested for syphilis, chlamydia, gonorrhea, trichomoniasis, and HIV-1 uninfected partners were tested for HSV-2. Now, what did they found? They found 6% were affected by a treatable STI, and among these, both partners were infected in almost 1/5. A treatable STA was found in 11% of females and 7% of males. And the most prevalent infection is trichomoniasis, followed by syphilis. I am sure if you do the similar kind of a study among the people accessing ART center, you will definitely find something like this, both for trichomoniasis as well as syphilis. And the same thing holds true even for herpes simplex virus too. So what they are saying is treatable STIs are still common among HIV-1 discordant couples. Awareness of STI correlates and treatment of both partners may reduce HIV-1 transmission, which is very relevant as we observe almost 30% of serodiscordancy in India across different ART centers. In another paper from Uganda, they studied about the sexual behavior among persons living with HIV. They wanted to see what will be the implications for policy and practice. So they say that those PLHIV who are addicted to substance abuse such as alcohol or maybe drugs, you require an intervention which also reduces the substance abuse habits. Then only you will have a major benefit or a major outcome to avoid HIV transmission and prevent acquisition of new HIV strains and STIs. And the second most important, culturally it is also equally important for a country like India where people insist to have children. We need to have a specific strategy and a counseling mechanism to address the needs of PLHIV who desire to have more children or at least one child if they happen to be got infected before they conceive. So this is the rationale behind why we are discussing today the STI and HIV is the synergy and management. Are there any questions at this point of time? Are there anything if people wanted to have a clarification? Or shall I go ahead? Okay. Now let us go into the second topic, that is the interactions between the STI and HIV. Now I am sure most of you must have seen this classical slide. Now what is the interaction between these two? When both of them are STIs, then why are we talking specifically? Yes, both of them are STI, but then the point here is HIV is known to suppress immunity, which has a lot of bearing. Okay, the HIV induced impaired immunity will make individual more prone to acquire STDs or STIs. The frequency may be more. If they are already infected with HSV, the recurrence rate may be more. It may alter the natural history, like for example in syphilis. It may shorten the duration, or it may manifest at an early stage, later complications. On the other hand, the high risk sexual behavior actually individual prone to acquire either STI other than HIV or HIV or both. And they also enhance transmission risk and progression to clinical disease from the asymptomatic to symptomatic phase. Now let us see the effect of STI and HIV susceptibility. You have a table here. On the first column we are describing the different STIs both in terms of syndrome and in terms of individual STI. And in the second column we are describing about its effect on male to female, and in the last column it is describing its effect on female to male. Now, if you see the genital ulcer disease, ulceration on the genitalia which is easily visible to the eyes. It may be due to bacterial treatable curable causes, or it may be due to treatable but incurable viral causes, or it may be due to other causes also like trauma and all, but that we are not discussing. Suppose in case you have a genital ulcer disease, what will be the effect on HIV susceptibility? It is around 2.8 times if the ulcer is there on the male, and if it is in the female, the effect is almost getting doubled. If there is a HSV in the male, what is its effect on HIV susceptibility in the female? Currently we do not have sufficient data to discuss on this, but there is a data available to discuss if it is there in the female, what will be the risk to the transmission to male. That's about 2.7%. If you diagnose syphilis, then the risk varies between 2.1 to 2.5, not much difference between both of them. Chancroid, it is also one of the commonest cause for genital ulcer disease along with syphilis. So the risk is around 2.3 and 2.1. If it is a gonorrhea or a chlamydia, both will cause discharges. There the risk is less when compared to male to female to female to male. It is almost more by about 1/3 in female to male setup. Whereas in trichomoniasis, no, the data is not there. It's the effect of the STI on the male from the female. But whereas we have the effect from the male to female scenario, it's around 1.5 and candida is 2.2. And similarly bacterial vaginosis. If you noticed here, the last two are not STIs. That means no, their mode of transmission is not sexually and most of the time it is associated with poor genital hygiene, with the douching practices, with inadvertent uses of the antibiotics, and so on and so forth. So these are labeled as a reproductive tract infections, but then even RTIs has a bearing in the HIV transmission and the susceptibility risk, and this is a point which we have to keep in our mind. Now, how the STI increase HIV transmission? Number one, mucosal disruption. Whether it is an ulcer or a discharge, it may cause disruption of the mucosa of the genitalia or anorectum, thereby increasing infectiousness and making them more susceptible. Then target cell recruitment and activation. This is another important feature. Altered cytokine production, reduced CD4 counts, impaired HIV specific cytotoxic lymphocyte function, and enhanced replication of the HIV. All these parameters increases the infectiousness of the HIV infected individual and also make the who is not infected with HIV but infected with STI as a susceptible guy to acquire HIV transmission. So on many different counts, the HIV and the STI has a synergy, facilitate each other in getting transmission from one to other. Now, STIs are associated with increased detection and concentration of HIV-1 shedding. The meta-analysis of 39 studies evaluating impact of STIs on genital tract HIV-1 DNA or RNA. The meta-analysis was done in January 2008. It was published in the Journal of STD in 2008. Now what it says is, genital viral load. We all know the plasma viral load. And we also know that there is some amount of viral load in the genitalia, which is also important, rather which is very critical when we don't have a detectable viremia in the plasma. So this is proved to be one of the important variable in transmission risk. So in the presence of an STI like urethritis, there are 3 studies which studied about the urethritis impact. There will be an increased genital viral load. The same way, in the presence of cervicitis caused by either gonorrhea or chlamydia, the genital viral load gets increased. A simple vaginal discharge due to trichomoniasis, it increases or enhances genital viral load, but the meta-analysis failed to prove whether bacterial vaginosis has the same or a similar effect. When you look into the syphilis or herpes, both causes genital ulcers, they also increase genital viral load. Now what we are trying to say by all this is there is a sufficient synergy between the STI and HIV, both in terms of behavior, in terms of epidemiology, in terms of immunology, which enhances the risk of acquiring or transmitting. That is the bottom line of this the papers. Now, impact of STI and HIV viral load, if you can see this, see the first diagram here. Risk of HIV transmission per coital act. Okay. Now on the left hand axis we are showing HIV RNA in semen, and then in the bottom line we are seeing the duration. So in different stages, during the acute infection stage, during the asymptomatic period, during the progression of HIV, and during the stage of AIDS. So the risk of HIV transmission varies in each stage per each coital act. It varies anywhere between 1 in 50 to 1 in 100 between the various stages. Now if you look into in the presence of an STI, what will happen? During all the stages, the risk is getting enhanced. Irrespective of what stage he is of the HIV infection, presence of an STI is increasing the HIV viral load, thereby enhancing the risk of HIV transmission per coital act. Okay. If there is no gonorrhea, the HIV genital viral load is around 19%. If there is a gonorrhea pre-treatment, it's about 44%. Once you start treating, it has reduced by almost half. Okay. Now, after discussing the interaction between the various STIs and HIV, now let us have a quick overview about the syndromic case management. Now, syndrome is what? A syndrome is a combination of a group of symptoms and the signs which are caused by many different organisms, or at least more than one organism, which has a common kind of a presentation. They are clubbed into one syndrome. The basic premise of syndromic case management is it offers treatment at the first contact. It enables us to treat the index case, thereby reducing the infectiousness, thereby reducing the onward transmission. And unlike many people think that syndromic case management is not a scientific tool, but it is absolutely based on the scientific principles. It follows a certain decision taken at each and every step. It never compromises on the quality part of that. Provided we practice, understand and practice every step of syndromic case management, it delivers equally good results, except in two syndromes that we will see what are they and how do we address that. Now, before we go into the syndromic case management, let us see what are all the various approaches to manage a case of STI or RTI. One is the traditional clinical approach. I, being a specialist in the STI, I look at the individual based upon my experience, my knowledge, my clinical acumen. I say, okay, this could be this, and I treat. Okay, this is the most classically followed by majority of the clinicians, citing various reasons. The second is laboratory assisted approach. Now a case has come, I'll keep the guy waiting. I will now start doing the battery of investigations, and usually most of them are routine, simple investigations, because most of our health infrastructure do not have latest STI diagnostics. If they have the equipment, they don't have the kits. If they have the kits, they don't have the equipment. If they have both, there is a lot of time is required, lot of money is required. Okay, keeping all this, it's a kind of a costly kind of approach, but then definitely it is a worthwhile approach, because you are not over-diagnosing, you are precisely delivering. But the limitation here, suppose your laboratory screening, or no matter whatever the level of the STI diagnostic kit, if not a simple antibody test, you are doing a NAT based investigation. Suppose if these investigations come out negative, can we rule out absolutely the possibility of an STI? No, we can't. So at the end of the day, after spending a huge money and time, and on which there is no guarantee that we can hold the patient, or he may turn back again for the treatment or to receive the lab results. So we are leaving an individual who has come to us for treatment without offering treatment with the same condition, and probably he may be transmitting this before he finds some other person who is willing to treat him, or maybe an unqualified person or a quack also. Then the last is the syndromic management approach. It will overcome the limitations of the above two. Henceforth, in 2007, after a lot of deliberations, Government of India has adopted syndromic case management as the core management strategy and introduce the same across all levels of health facilities, including the private sector, to manage commonly seen and observed STI, RTI in different populations, including people living with HIV. Now, at this point, we should also learn a little bit about RTIs. Now, what are these RTIs? Reproductive tract infection. Reproductive tract is an anatomical part in the human body which is primarily responsible for reproduction. That means to produce the next generation. It is present both in men and women. And then, because these sexually transmitted infections predominantly happen in the reproductive tract area, all STIs are automatically RTIs also. When coming to the women, the reproductive tract infections also include conditions like candida, conditions like bacterial vaginosis, which we have discussed earlier. It also includes infections induced following delivery, following abortion, or unhygienic practices of introducing IUCDs, or using unsterile equipment to do an internal examination, all such kind of a thing. That means where there is no sexual role, but because of the inadequacies on the health system or a healthcare provider, the individual is acquiring infection, and it is mostly limited to the reproductive tract, and these are very, very important with reference to the women. Similarly, the reproductive tract infections in the men also include prostatitis and epididymitis, which are not primarily associated with STI. Now, prostatitis and epididymitis can also happen as a complication of STI, but here we are discussing non-STI causes of the prostatitis and epididymitis. They principally constitute reproductive tract infection in the men. Now, let us see what are the advantages of the syndromic case management. Why Government of India has been advised by the Technical Resource Group to adapt this as a universal strategy. Number one, it is fast. We can diagnose and treat the patient at the first contact. Number two, it is relatively inexpensive. Number three, there is no need for patient to wait for the lab results, and it can be practiced irrespective whether you have laboratory support or not. Number four, all possible STIs causing common symptoms and signs can be treated in one go. It is scientifically proven as one of the cost-effective strategy to manage the STI RTI, not only in India but across the world. It is easy to learn, easy to teach, and easy to practice by any level of healthcare provider. Need not have a specialist. Easily can be integrated into the existing primary healthcare services and to universal health coverage strategy of Government of India. Can be implemented by any kind of a healthcare provider. For example, even the colleagues working in the department of Ayush, the Ayurvedic, Unani, okay. So these people also can easily learn and can easily practice this. Of course, if there is a direction and a monitoring support by the MBBS qualified doctor, it will be added advantage and it is desirable. And it is also facilitate standardization of the treatment regime across, because you are giving a universal kind of a treatment strategy. It is easy to standardize, easy to monitor, minimizes antibiotic resistance. It also facilitates procurement and supply chain management. But at the same time, all that is associated with the syndromic case management is not rosy. There are certain valid limitations. Some conceive them as threats. Now let us see what are they. By default, a syndrome, we said that is a combination of a symptom or a sign. If the individual do not have neither symptom nor sign, we cannot use the strategy of syndromic case management. That means it is not a useful strategy in asymptomatic population. And we also know that lots of STIs nowadays, because of the inadvertent use of the antibiotics, is mostly asymptomatic. That means syndromic case management is not a feasible or a useful strategy to manage latent or hidden STIs. It definitely has an amount of overtreatment. Therefore, the cost of overtreatment is there as well as side effects. There is also a cost associated to manage the side effects. There is also a potential for antibiotic resistance development, but it can be minimized if you can really understand each and every step of syndromic case management and adheres to that quality. But still there is a possibility of threat of emergence of antibiotic resistance. And syndromic case management proved to be having very poor sensitivity and specificity in managing syndromes such as vaginal discharge and lower abdominal pain in the women. So those are the actual limitations. Now let us see what are the common STA RTS syndromes in men. Okay, before we go, is there any questions on this? Okay, what we have done, we have revised the national technical guidelines last year. We have addressed many of the issues associated with syndromic case management in those guidelines, which we will also briefly take up in the subsequent slides. Now let us see quickly go through the common ST-RTA syndromes in the men. The most important is urethral discharge syndrome. What are the causative organisms? Gonorrhea, chlamydia and trichomoniasis. What is the treatment we offer? A stat dose, 1 gram of azithromycin plus 400 milligram of cefixime, ideally to be given by you, in front of you, in your center. We will never give these medicines to the patient, because to ensure 100% compliance, we make sure that the individual swallows that in front of us. Please do not bother about the gastric intolerance, this and that. We had enough evidence. There is nothing. Whatever is there, it is very minimal. It can be addressed. You can keep for an hour if you want the individual after taking the tablets in the center. The second most important is genital ulcers. Chancroid, syphilis and genital herpes are the most common causes of the genital ulcer. Of course, in certain areas there may be granuloma venereum or otherwise called donovanosis, especially in the south. We see this as another important cause of the genital ulcer. Now we have two different varieties of managing these genital ulcers. One is a combination of azithromycin 1 gram plus 2.4 million units of benzathine penicillin as one dose, provided the individual is not allergic or hypersensitive to penicillin. In case he is hypersensitive or you do not have the adequate resuscitation measures with you, then you can resort to the alternative therapy, that is the 1 gram of azithromycin plus 100 mg doxycycline twice a day for 15 to 30 days, depending on the duration of the acquiring syphilis, early or latent. If it is early, less than 2 years, then we give for 15 days. If it is more than 2 years, we give for 30 days. And similarly, the benzathine penicillin dose has to be given one dose. If it is less than 2 years, if it is more than 2 years, then you give 3 times. For genital herpes, we give acyclovir 400 mg 3 times a day for 7 days, irrespective whether it is a primary attack or a recurrent attack. The third important syndrome is inguinal BIBO, caused by lymphoclangioma venereum and probably the chancroid, which will cause inguinal BIBOs. Then the treatment here, azithromycin 1 gram, stat dose plus doxycycline 100 mg twice a day for 21 days. Remember to give stat dose in front of you in the clinic. Never give the stat doses to the individual, because ensuring compliance is a big challenge. Then the scrotal swelling, or otherwise called a painful scrotal swelling syndrome, is a complication due to poorly managed or untreated gonorrhea and chlamydia. Treatment is the same like urethral discharge, azithromycin 1 gram plus cefixime 400 milligram, stat dose. Anorectal discharge, again due to gonorrhea and chlamydia, the treatment is azithromycin plus cefixime. And oropharyngeal gonorrhea, treatment is again the same. That means these organisms will choose the site depending on the sexual behavior the individual has practiced. Is it a genital, oropharyngeal, or anorectal? Then genital skin conditions like genital warts, molluscum contagiosum, pediculosis pubis, genital scabies, which may sometimes turn into Norwegian scabies, especially in HIV infected individual with lower CD4 levels. Now this we manage with not in a syndromic way, but through extirpation for the molluscum and a cautery, either chemical or topical electrical cautery or nitrous oxide application for the warts, and topical applications for other things, and probably ivermectin for genital scabies, including Norwegian scabies. Now, what are the STI-RTI syndromes in the women? The most common syndrome which everyone sees is the vaginal discharge syndrome caused by trichomoniasis, candida, and bacterial vaginosis. And the treatment is a stat dose of secondazole 2 gram plus fluconazole 150 milligram. Vaginal discharge is the other component of vaginal discharge, which will manifest as a vaginal discharge, but actually the discharge is coming from the cervix. The commonest causes are gonorrhea, chlamydia, trichomonas, and herpes. The treatment, azithromycin plus cefixime. If you suspect herpes, we have to give acyclovir 400 mg thrice a day for 7 days. Then the lower abdominal pain. It is actually pelvic inflammatory disease, a complication of untreated or poorly treated cervical infection, and it can be due to gonorrhea, chlamydia, and also can be due to non-specific organism like mycoplasma, Gardnerella, and anaerobic bacteria. The treatment is cefixime 400 mg once a day, a single dose, plus metronidazole 400 mg twice a day in combination with doxycycline 100 mg twice a day for 2 weeks. Genital ulcers, syphilis, and chancroid, and genital herpes. The treatment is azithromycin plus benzathine penicillin or azithromycin plus doxycycline with or without acyclovir. Anorectal discharge, again it may be due to gonorrhea and chlamydia. Throat infection, same gonorrhea and chlamydia. Please don't be under the impression that anorectal discharge in a woman doesn't mean always anal intercourse. Anorectum may also get infected even without the anorectal exposure because of the anatomical configuration of the woman. But still, if that is suspected, then the treatment is same like in cervical discharge. Similarly, the genital skin conditions, what we see in the men are also seen in the women, and the treatment is exactly the same. Now, this is a job chart which we have designed under the program, and I hope that every ART center has one of these in their treatment centers. It is actually, at a glance treatment management follow-up kind of a center, kind of chart, which will enable very quickly and empower so that it minimizes errors in diagnosing, errors in treatment, errors in following up, and in the proper documentation. Okay. Now, most important point is the partner treatment. Partner treatment of index cases is always important whenever you diagnose an STI syndrome. But it is not important if you diagnose an RTI syndrome unless until the partner is symptomatic. The only word of caution is if you diagnose a herpes simplex virus or a viral genital ulcer disease, we do not routinely offer partner treatment. So please remember this. The reason behind, by the time the individual has come to us, he has already infected his partners. Therefore, unless the partner manifests herpetic signs or symptoms, we usually do not routinely treat the partner of herpetic case. We have standardized the management package under the STI-RTI program for general population and for the high risk groups, or otherwise known as most at risk population. So we manage the symptomatics as per the syndromic case management protocols, and we use minimal laboratory tests wherever they are available and feasible without losing the index case. And in case of the HRG, especially female sex worker, MSM, transsexual and transgender and IDU population, We offer a presumptive treatment to take care of gonorrhea and chlamydia. It is not extended to bridge group. It is not extended to the general population. We also counsel and test all attendees of government-sponsored designated STI clinics for syphilis and HIV. We motivate them to visit the nearby ICTC and undergo this test. Whereas in case of HRG, we encourage them to come and seek the services checkup by the doctor once in every 3 months. This is what is known as regular medical checkup. The rationale behind this is it induces health-seeking behavior. Then we also follow cases where treatment has not given the desired result or unresponsive cases. These will be referred to the network of laboratories which are there around 55 spread all over India. Their primary job is to etiological monitoring of the STI, monitoring of the gonococci for its antibiotic sensitivity, and also look for the cases for treatment failure and treatment unresponsive cases. Among the HRG, we do screen them once in 6 months for syphilis, which we use as an indicator for their condom usage, for their sexual behavior patterns. We also screen all pregnant women attending ANC clinics, both for HIV and for syphilis, because Government of India is committed for dual elimination of both HIV and syphilis. Both has got the risk of transmitting the infections to the newborn. Henceforth, we wanted to prevent that to happen, and this is the Government of India's newer initiatives. We encourage HRG once in 6 months to get HIV counseling and testing along with syphilis. This is the standardized package and which will empower the individuals to practice Then what is the role of STI in HIV prevention? Now we learned about the rationale, we understood about the synergy, we have seen what is the kind of management principles. Now, is there any role of STI in HIV prevention? Definitely there is a role, there is a lots of literature is available. Now safe sexual practices reduces the chances of HIV sexual acquisition for those who are HIV negative, and regular STI screening both clinically and lab based is very, very important, and this regularity you can decide based on the risk behavior of the individual. But at least at the initial point, at the first contact period, at the first time you register, irrespective of CD4, kindly take a detailed history, kindly screen them for the possible STI, whatever tests which are available, at least minimum you should screen them for serological evidence of syphilis. Okay. Now safe sexual practices reduces the chance of HIV sexual transmission for those who are living with HIV. That means people who are coming regularly to us either on ART or on pre-ART. Please institutionalize, practice routine STI screening both by clinical. When I say clinical, take a detailed history, look into the oropharynx, look into the genitalia, look into the anoproctodium, apart from the looking into the overall general health system. And this frequency you can increase depending on the risk behavior and other epidemiological factors associated with the individual. Now if you look into the integration between the STI and AIDS program in the entire cascade of the HIV treatment and care, if you look there is a blue lines and there is a red line. If you look into this, the STI program has to be implemented fully in integrated manner in all the centers where the care for HIV infected individuals is happening. Whether it is a community care center, whether it is a drop-in center, whether it is a ART center, or it is a link ART center, or is a center of excellence, at every one of this point you need to have STI service as an embedded kind of a treatment package. And wherever there is a diagnosis of HIV is happening, you need to link them up for the STI program. Similarly, wherever there is an STI program diagnosis is happening, they need to be referred for HIV diagnosis. So this referral linkage is equally important at both the setup, both at the HIV or STI diagnosis and as well as the referral linkage between STI and HIV services. Now look into the treatment centers, both at the STI treatment centers as well as at the RT centers. There should be a cross referral linkage. You need to identify and manage the STIs at the appropriate. Similarly, the same thing will happen at follow-up visits and subsequent follow-up visits also. Even among those who are having suppressed viral loads, please remember, sex is a basic instinct. They are always at the risk of getting STI, if not an HIV. Then among the people who are lost to follow up, there is a role, there is an importance between both for STA program and for the HIV clinic, as well as among the population who are exposed to the or who are being given pre-exposure prophylaxis. That means at each and every step of the HIV treatment and care cascade, there is a role, there is a need to integrate and practice STI component, STI screening and treatment component. Now, in terms of pregnant women, now some of the PLHIVs may also be pregnant, and is there any specific need to role to manage STIs? Yes. Now, these are I have given the slides. You can read later. I think we are short in time. Now, different STIs have got some kind of an effect on the pregnancy as well as on the newborn. And I have given in this table what is the effect of STI and pregnancy in neonate and effect of pregnancy on STI. Okay, so both the STI and pregnancy on STI has been given, but this is very, very important to understand because they will have a lot of bearing, and this has to be kept in mind in managing. Now, coming back, most important, how do we manage certain STI among the PLHIV community? Number one, syphilis. Although syphilis is uncommon, unusual serological responses are observed among PLHIV. Neurosyphilis should be considered in the differential diagnosis in the neurologic disease in HIV infected persons. HIV infected persons should be evaluated not only clinically but also serologically for a possible treatment failure at 3rd month, 6th month, 9th month, 12th month and 24 months after therapy. Please ensure, please make sure you have to document this in your white card, and please pay attention to this. At this point of time, I am not sure that this is happening across centers, but please make sure. CSF examination retreatment also should be strongly considered for persons whose non-treponemal test titers do not decrease fourfold within 6 to 12 months of an effective treponomicidal treatment. HIV infected patients who have chancroid should be monitored closely, as there is a possibility of the chancroid becoming unresponsive, or it may also end up in auto amputation. And maybe they require a longer courses or a repeated course of therapy. And similarly, patients with granuloma inguinale should receive the same regime, but be aware there might be a need for a parenteral aminoglycoside such as compromised patients can have prolonged or severe episodes of genital, perianal or oral herpes. The viral shedding is increased, and what we have introduced is suppressive therapy. If there are more than 6 recurrences in a year, these individuals are eligible to be started on HSV suppressive therapy for a minimum period of 1 year. The second possibility is acyclovir resistant strains, and they are also supposed to be resistant to the valacyclovir, and are also most of them found to be resistant to famciclovir. In case you are coming across unresponsiveness to the acyclovir, then the alternative treatment what is being recommended in the national guideline is foscarnet 40 mg per kg intravenously to be administered once in 8 hours until clinical resolution is attained. Okay, so or intravenous cidofovir, but then probably it is better to refer these cases to the higher centers or center of excellences because that will be more important. Okay. Now, recurrent vulvovaginal candidiasis, as we all know, is one of the key marker of the immunocompromisation, and these women has to be tested if they are already not tested for HIV. If it is happening among the PLHIV, they need to be educated about the genital, menstrual and coital hygiene, and then be also aware about the fluconazole resistance, which is gradually emerging across India. And the treatment is same, it doesn't differ. Bacterial vaginosis recurrence seems to be higher in the HIV positive women, but the treatment is the same. Trichomonas vaginalis infection, which is we already learned it enhances HIV transmission risk, but then the treatment is also same, but rescreen them 3 months after completion of therapy. That is very important to ensure that the individual is completely cured. If there is a recurrence, the treatment remains the same. Okay, and you can also encourage them to undergo once in 6 months cervical cytology through pap smear at the distant level, so that we can identify in the early stages abnormal pap smears and take appropriate referral linkages. Okay, to sum up, syndromic management is a scientific and proven approach. Please get comfortable in getting a sexual history. If you are having any inhibitions, please get rid of them. Ensure that you have adequate privacy, not only for you and as well as to the patient. There should be an adequate audiovisual privacy in obtaining the sensitive information. Check their oral cavity, anorectum and genitalia. Minimum annual screening for STI is recommended, but you can increase the frequency depending on the customized risk behavior. And partner notification, risk reduction counseling for both patient and partner is very, very important. And you also ensure follow-up to ensure the treatment is complete and there is a symptomatic cure. And then syndromic approach does not deny use of laboratory test. In case you are having a laboratory support, a good laboratory support, do get the laboratory screening is done, but do not postpone the treatment. You should offer the treatment and do not keep the patient waiting for the lab results. Syndromic case management goes beyond pharmacological treatment, and it includes not only partner treatment but also counseling, screening for syphilis, condom demonstration and provision, and most importantly follow-up and document records. Emphasize that most important point is that patients may have an inhibition that whatever information, their personal information they are sharing with us, whether it will be kept confidential or not. So at every given point we have to emphasize, we have to ensure, we have to tell them very boldly and very confidently that the data what they are sharing will not be shared with any individual without their consent. So this will go a long way in getting the appropriate and adequate information what is relevant for you to make an appropriate diagnosis. Now I think we went in a very fast forward mode, and then let me stop at this point of time. Let us see, is there any questions from your side? I couldn't see you were chatting, but then probably, yeah, somebody is asking what about drug shortage in DSRC. Now drug shortage, there was a shortage with reference to the syndromic color coded kits. There was no shortage with reference to the loose medicines. We have given n number of times instructions to all the state AIDS control societies, because these drugs are available everywhere. These are the generic medicines. These are the national essential list of medicines. That means every hospital, every public health facility should have these in adequate number. So if you do not have color coded drug kit till you get them, please ensure the treatment is offered as per the syndromic case management protocol. That means if you don't have a grey color kit, but if you have got azithromycin and if you have got secnidazole or secnidazole and fluconazole, azithromycin and benzathine penicillin, you can give. Okay, if you do not have secnidazole, you can give metronidazole, you can give tinidazole, you can give ornidazole. So this is the n number of alternative options are available, but ensure that the treatment is very, very important. Let us not go by the availability or a shortage of the color coded kits. Remember, color coded kits is a management strategy. It is not the only and the whole and mode of treating the STI-RTI. Okay, I do agree it's a best practice, but still you can manage the cases with available generic medicines. Okay, yeah, regarding drug resistance antibiotic policy, single dose regimen, sir, yes. Regarding drug resistance, we have a network of 55 laboratories. They are on constant vigil. We are also monitoring from here. So far, in the last 7 years, we haven't seen a case of drug resistance. The drugs what are being advocated in the STRTA program seems to be working wonders. And antibiotic policy, yes, antibiotic policy is there. Irrational use of antibiotics should be curtailed at every level. There is also a detailed pharmacovigilance which is coming up under the DGCI, and probably by next year it will be a full-fledged. Even WHO and other UN agencies are also paying a lot of attention towards the rational use of antibiotics. Now, single dose regimes are most advantageous. The reason because you can ensure 100% compliance as long as you are using appropriate drugs as a single dose regime, which are found to be effective, which are found to be curative with single dose. They are most ideal. But in terms of complications, single doses may not be ideal. There you have to give extended period of treatment. And remember, whenever you give extended period of treatment, compliance is a major challenge. That's where the counselor's role will come into. That's where the follow-up and documentation of that plays a major important role. And we have to use the networks, the community members from the network to ensure 100% compliance whenever we are giving multiple doses or extended duration doses. Okay, then anything else which I am missing? Okay. So if there are no questions, we will end up this session with this. Okay, okay, right. Yeah. Okay. Now there is a very interesting question which has been raised by one of our colleague. Recurrent herpes genitalis in people living with HIV/AIDS can reduce CD4 count. Definitely it can reduce CD4 count, and what WHO stage should be considered? Now we always advise you do not measure CD4 in the presence of a active infection, because active infection always compromises your CD4 measurement. It is a biased result. So you try to suppress the or treat the current episode, then measure the CD4. Probably it reflects the true level, and based upon that you can do a WHO staging. And moreover, no, in the current guideline, I'm not so sure about the CST program guideline, but then no, if you are using the clinical staging, there is no relevance for CD4 based kind of a staging. But whenever you have a CD4 based staging, you should not try to measure CD4 in the presence of any infection, not only STI. In the presence of active infection, your CD4 counts always come low. That may not be a true level. Okay. Then possibility, what about drug cross reactions? Yes, drug cross reactions do happen, no doubt about that. No, we need to look into the drug to drug interactions, and especially when we are giving to the fluconazole, when you are also putting the individual and the ATT, and where the individual is also there on the PI based regimes, there will be definitely drug to drug interactions. We have to be aware to that. And fortunately, the treatments we are offered under the STI management are mostly single dose for a limited period of time, and we need to forewarn the individual and to come back and report to us about the silent drug interactions, so that we can able to take appropriate action. Okay, then there is also repeated herpes genitalis, how to manage. Now, repeated herpes genitalis, we have already said that we have addressed this issue in clinical guideline. Therapy, if the recurrences are more than 6 in a year, The suppressive therapy can be given for a minimum period of 1
Thank you very
year.
much, sir.
You can reassess
Dear
the individual.
participant,
If
as
still
sir has
recurrence are
addressed
happening,
all of the
then
questions
the
which
case
were
has
there
to
in
be
the
referred
chat
to a
box.
higher level
We
than
still
you,
request if you have any
maybe
question,
to
you
a
can write it down in
nearest
the chat
regional
box.
STA lab
Sir
or
can
the
eligible respond on
nearest
that.
state
On the left
STA
side, you
lab.
can see there is a
The list is
e-poll.
there on the
Please
website
vote on
in the
this
NACO
e-poll.
program. You can look into this. And these are the
The
sites which will
correct
help
link
you
in the
out to
presentation
understand
along with the
whether
question and
whether
answer will be
the
forwarded to
herpes
you
is due to
shortly.
acyclovir resistant strain. Then in that case, you need to go for alternative options.
So we thank you all for participating in
Yeah, I
NDLS
think
sessions.
I have
Thank you so
covered
much.
the
Thank you,
other
sir. Thank you all.
questions. Yeah.